Hello, my name is Dr. Satija. I'm a cardiologist and cardiac electrophysiologist. I specialize in the treatment of arrhythmias, and I practice at HCA East Florida in several hospitals in Broward County. Today we're going to talk about atrial fibrillation, or AFib. AFib is a common arrhythmia, an abnormal heart rhythm. It's the most common heart rhythm problem that I see as an electrophysiologist, or that in general we see in adult patients. It's a fast, irregular heartbeat that is more common as you get older, but can be associated with other forms of heart disease as well. It makes the heart go fast and irregular. So atrial fibrillation is partially an age-based phenomenon. So as the US population gets older, we see a lot more of it. Especially here in South Florida, where we tend to skew geriatric, we see a lot of atrial fibrillation. That being said, so if you're over 70, there's almost a 1 in 15 chance of having it. We do see it in younger patients. It can be associated with obesity, it can be associated with other heart disease, valvular problems, prior open heart surgery. You can even get it spontaneously. I've had patients as young as 22 and as old as 102 with atrial fibrillation. So atrial fibrillation has different symptoms depending on the patient. Older patients tend to feel tired, short of breath, just lethargic. Younger patients will actually feel palpitations, pounding, racing heartbeats. Young patients, for instance, who will tell me precisely, I have AFib, it started at 1:10 in the afternoon, it lasted 3 hours, and they can say when it started and finished. My older patients often don't notice it, and so you have to monitor them in some way to figure out how much they're having and what the burden is. In some people, it can be completely asymptomatic, and that can be problematic as well because it can cause strokes. So certainly if you're having racing palpitations that come and go, you really should see a cardiologist and wear some sort of monitor to see what's going on, because that could be a first sign of a dangerous arrhythmia, including atrial fibrillation. On the other hand, if you're just tired and fatigued, especially if you're older, still seeing a cardiologist and getting a good workup to see what's going on is quite reasonable, because the symptoms can mean a lot of different things. But certainly if you're having abnormal pounding heartbeats, it's obvious that there's possibly something going on and you need to be monitored. So typically atrial fibrillation can be diagnosed off an EKG, which is a 5-second, very quick and easy diagnostic test that any primary care doctor, emergency room, or cardiologist can do. That being said, an EKG is a 5-second snapshot. It tells you if you're having AFib at that moment. It doesn't tell you if you had it earlier in the week, a month ago, 2 years ago. So even if you've had normal EKGs with your doctor, it doesn't mean you don't have the disease, it just means you didn't have it when it was recorded. So a lot of times we use different forms of prolonged monitoring. You wear a monitor for a day, 2 days, a week, sometimes even a month, or sometimes we even place semi-permanent monitors in certain high-risk patients if we're really worried about the disease. The biggest problem with atrial fibrillation is that it causes strokes. So specifically, especially as you get older, or if you're diabetic, you have high blood pressure, or if you're female, that risk for stroke starts to elevate. Oftentimes we use blood thinners, Eliquis, Pradaxa, Xarelto, Coumadin to protect patients from stroke. Even then, while blood thinning is very important, you also want to control the disease itself. If you intervene early in the disease, especially in a younger patient, you can slow or halt the progression. If you sit on it for a long time, the longer you've been in it, the less likely you are to ever get out of it. It can make the heart race, and over time, if the heart races too hard, it can weaken the heart muscle and cause permanent damage. We have a gamut of options from simple to very complex for AFib. We do state-of-the-art treatments. So simple are things like pills, blood thinners, heart-slowing medicines. Sometimes we'll shock patients out of AFib to end their episode. That's simple and easy and very safe. Doesn't have good long-term effectiveness, but it allows us to help manage the disease process. It's not uncommon, especially in a younger patient, to do things called catheter ablations, where we go in with catheters and freeze or burn the areas that are driving the AFib. That's a very common therapy. So AFib can happen just because of age. That being said, obesity or being overweight, especially if you have untreated sleep apnea, is a big risk factor. So I stress weight loss. I often work hand in glove with my sleep specialist to treat sleep apnea if it's undiagnosed. Alcohol is a factor, so alcohol cessation or decreasing your alcohol use is important. Similarly, in general, you want to be on a heart-healthy diet, low salt, low saturated fat. That's less applicable to an AFib patient than it is to my general cardiac population with blockages in arteries and stents and heart attacks. But it's still important to know.